Thank you very much, dear students, for being present. You are well aware that today we'll discuss about the management of the diabetes mellitus. Since we are discussing about the endocrine module, the topic which have been assigned to our department today is that of diabetes mellitus. So we'll be discussing about the diabetes mellitus, the definition, the signs and symptoms, the diagnosis, investigation, and the proper diagnosis, and then of course the drugs used for the management of the diabetes. So, for the drugs are concerned, we'll be discussing about the pharmacology of the drugs, the mechanism of action of drugs, the adverse effects, and contraindications if any. So after this presentation, we will continue with the couple of videos related to the diabetes mellitus after this presentation, immediately after this presentation, and then we'll proceed to the Edmodo activity. We'll assign you the task, the questions related to the presentation, and that you will have to complete well in stipulated time, whatever you are assigned to that. As you are well aware, diabetes, dia means through, benign means to go, a term referring to disorder characterized by excessive urine excretion, polyuria, in diabetes mellitus as well as in diabetes insipidus. Diabetes insipidus is entirely different from the diabetes mellitus, but this symptom you will observe in diabetes insipidus as well, that there's polyuria. So diabetes mellitus is a condition in which there are faulty carbohydrate metabolism, mainly due to lack of insulin. This results in hypoglycemia and glycosuria. Diabetes mellitus is a disease of metabolism characterized by inability to utilize carbohydrates. The blood sugar is increased, and when it exceeds a certain amount, that's about 180 milligrams per 100 milliliters, the excess glucose is secreted by the kidney. This condition we call glycosuria. So when the blood sugar is increased beyond certain limits, that may be the maximum limit of 180 milligrams per 100 liters, the excess glucose is secreted by the kidneys. This condition is known as glycosuria. What are the different clinical features and symptoms you can observe in a patient? As we are discussing about polyuria, more urinary output, polydipsia, thirst, polyphagia, more eating, weakness usually is observed in patient who is suffering from the diabetes mellitus. Body weight loss usually, but that varies from person to person. Some people are very obese and there might be some weight loss, but that's not mandatory for all the patients. For the diagnosis, you will have to carry out a few simple tests: urine sugar, blood sugar, glucose tolerance test, and then of course in glucose tolerance test you add 50 grams of glucose in 200 milliliters of water. Blood samples before and after the administration of glucose for 2 hours after every half an hour. So this indicates a sort of diabetes if the blood sugar do not comes to the normal after 2 hours. If within 2 hours blood glucose do not come to the normal, then the patient is diabetic. So this is glucose tolerance test. Another test which is normally carried out for diabetic patients to observe the control of the diabetes, that is sugar level, in the past 3 to 4 months. For that, we will have to perform HbA1c, glycosylated HbA1c will give the control of the sugar in the past 3 to 4 months. And normally the range is between 4.4 to 6. If it is above 6, above 6.6, it's likely the blood sugar level is not maintained properly in the past more than 3 months. It is useful to prevent various complications of diabetes as retinopathy, nephropathy, neuropathy in known diabetics. You people are well aware that diabetes as such, when it is in control, probably one can have the normal life without any problem. However, if the blood sugar is not maintained properly, then it may lead to the various complications. That includes retinopathy, nephropathy, neuropathy in known diabetes. So it's how, when you look at the glycosylated HbA1c, you can assess the patient, whether the patient has maintained the blood sugar level for the last more than 3 months or not. If he or she is not maintaining, then you will have to advise the patient to maintain it to prevent the complications. And furthermore, you are well aware of diabetes is normally of 2 types. Type 1, that we normally call insulin dependent diabetes mellitus. Type 2 normally is the non-insulin dependent diabetes mellitus. Type 1 is also known as growth onset juvenile diabetes, or type 1 growth onset juvenile diabetes, or insulin dependent diabetes, IDDM, insulin dependent diabetes mellitus, type 1 diabetes mellitus, that is also known as growth onset diabetes or juvenile diabetes. And if you compare the type 1 with that of the type 2 diabetes, in type 1 there is complete lack of the insulin secretions by the beta cells of the islets of Langerhans. They are unable to secrete insulin and generally has its onset before the age of 20. That's why बच्चा लोग में जो होती है growth onset juvenile diabetes, normally वो 20 से above होती है, जिसको हम 20 से कम एज में होती है, जिसको हम type 1 और insulin dependent growth onset और juvenile diabetes भी कहते हैं. Type 2 is also known as non-insulin dependent diabetes mellitus, adult onset diabetes mellitus, or maturity onset diabetes mellitus. Maturity onset diabetes is, however, the result of inability to utilize the insulin that is secreted. Insulin, you are well aware, is secreted by the beta cells of islets of Langerhans. And as we are discussing type 1, there is complete lack of the secretion of insulin. In type 2, maturity onset diabetes is the result of inability to utilize the insulin that is secreted. Insulin is secreted, but is not to that extent so that sugar level may be maintained. The different drugs are used in the drugs used, different types of drugs are used in sleep. Oral hypoglycemic drugs, hydrogen alpha-glucosidase inhibitors. There is a different group of drugs that we use for the management of diet. So we have discussed about the beta cells of the islets of Langerhans. They contain the pancreas contains different cells. Alpha secrete glucogan and beta secrete insulin. As we have discussed about complications, that is the blood sugar is not maintained properly. That will lead to the complications. And complications could be diabetic ketoacidosis, nephropathy, neuropathy, retinopathy, cataract, and vascular response. So, you will have to maintain the blood sugar level in a proper way for the patient, and one can have the normal life if the blood sugar is maintained properly. And you are well aware if it is not maintained properly, that will lead to all these complications. Diabetic ketoacidosis, nephropathy, neuropathy, retinopathy, cataract, and vascular response. This is one of the complications of insulin. If you look at the figure, if there is excessive insulin administration, that may lead to the hypoglycemia. Diabetic, hypoglycemia, diabetic, एक होती है हाइपरग्लाइसीमिया की वजह से कोमा हो जाता है, एक हाइपोग्लाइसीमिया की वजह से कोमा हो जाता है. Another group of drugs, एक तो हो गई इंसुलिन, उसके डिफरेंट टाइप्स हैं, शॉर्ट एक्टिंग है, इमीडिएट एक्टिंग है, लार्ज एक्टिंग है, कौन सी कंडीशंस में कितनी देनी चाहिए सुबह शाम. और दूसरे इंसुलिन एज वी हैव डिस्कस्ड is mainly used in type 1 diabetes. But in type 2 diabetes, we mostly administer the oral hypoglycemic drug. अब oral hypoglycemic में different drugs आ जाती हैं, जिसमें sulphonylureas भी हैं, gluconides भी हैं, thiazolidine भी हैं, और अल्फा-ग्लूकोसाइडेज इनहिबिटर ड्रग्स. तो सल्फोनाइलूरिया पहला ग्रुप है. फिर पेगोनाइड्स में आता है फेनफॉर्मिन एंड मेटफॉर्मिन. मेग्लिटिनाइड्स, ये सल्फोनाइलूरिया की नई एक ड्रग है. एंड देन ऑफ कोर्स व्हेन you administer food, there is naturally an increase, normal physiological action that there is increase in blood sugar level. Insulin controls the symptoms of diabetes, mellitus, and the disease cannot be controlled satisfactorily by diet alone. Because you see, initially, if the symptoms are not severe, it's likely you can control mostly diabetes in initial stages with diet and physical activity. However, insulin controls the symptoms of diabetes mellitus when disease cannot be controlled satisfactorily by the diet and physical activity alone. And then, of course, diet control is necessary. Sugar and sugar-containing diet is avoided. This indicates sort of balancing the diabetes. If you look at the figure, increase metabolism, exercise and physical activity, they normally reduce the blood glucose level. And calories in check. If you look at the downstairs, the arrow showing calories increase blood glucose, they are likely to increase the blood sugar level. And on the right side, you look at the insulin reduces blood glucose. And illness and infection increase the blood glucose and more insulin is required. This is normally that if God forbid if somebody is having some sort of infection or illness, it's likely one might have to increase the dose of the insulin in those patients because illness and infection increase the blood glucose and more insulin may be required for that particular patient. अब इंसुलिन की जो मेन कंडीशंस हैं कहाँ देनी चाहिए? Juvenile diabetes, as we have discussed, type 1 or juvenile diabetes. Then of course in patients their oral hypoglycemic drugs cannot control them. As we are discussing type 2 diabetes, that we administer oral hypoglycemic drugs, sulphonylurea, biogonides, thiazolidine and alpha-glucosidase inhibitor drugs. But in patients where oral hypoglycemic drugs cannot control the disease, we can also use the insulin in such patients. And of course, diabetic coma and precoma. All diabetics with complications such as ketoacidosis, infection, congestive cardiac failure or retinopathy need to be administered insulin. So, juvenile diabetes in patients where oral hypoglycemic drugs cannot control the disease, in diabetic coma and precoma, and all diabetics with complications such as ketoacidosis, infection, congestive cardiac failure, or retinopathy. अब एक तो हो गया इंसुलिन प्रिपरेशन जो टाइप 1 में देते हैं, टाइप 2 में नॉर्मली जैसे हमने डिस्कस किया ओरल हाइपोग्लाइसेमिक ड्रग्स ही प्रीफर करते हैं मेजॉरिटी ऑफ द केसेस. हाउएवर इफ दे आर नॉट रिस्पोंडिंग प्रॉपर्ली वी कुड स्विच ऑन टू द इंसुलिन. So oral hypoglycemic drugs are used in type 2 diabetes जिसमें सल्फोनाइलूरिया है, बेगोनाइड्स हैं, थायोजोलिडीन इन्ड्यूरेंस हैं और अल्फा ग्लूकोसाइडेज इनहिबिटर. पहला ओरल हाइपोग्लाइसेमिक ड्रग्स का जो ग्रुप है वो सल्फोनाइलूरिया में आता है जिसको हम कहते हैं secretagogues. They are likely to increase the secretions of the insulin. जिसमें कौन कौन सी ड्रग्स आ जाती है? प्रोपेमाइड, टॉलबिटामाइड, एसिटाइजामाइड, डोलाजामाइड, ग्लेबिक्लॉप. ये हो गए sulphonylurea के drugs. If we look at the biguanides, fenformin and metformin are the two main drugs in the biguanides group of oral hypoglycemic drugs. Basic biochemical defect in diabetes is decreased entry of glucose in various peripheral tissues. Entry glucose की various peripheral tissues में नहीं होती है, and increased liberation of glucose into the circulation from liver. So insulin क्या करती है? Increases the entry of glucose into peripheral tissues. Insulin increases the entry of glucose into peripheral tissues. This means increases the peripheral utilization of glucose. So that blood में कम हो जाती है, peripheral utilization को बढ़ा देती है. This action of insulin is achieved on cell membrane receptor side. The insulin receptor combination increases the activity of carrier systems for facilitated diffusion of glucose and increase the conversion of glucose to glycogen in the liver and muscles, and decrease the glucose entry into the circulation. Blood में कम हो जाती है and increase the conversion of glucose into glycogen in the liver, muscles, and decrease the entry of glucose into the circulation. This is how insulin produces the action. अब इसके बहुत सारे preparations available हैं. Plain insulin, insulin zinc suspension, protamine zinc insulin suspension. अब उसके preparations के types जो हैं वो भी हम आगे चल के discuss कर लेंगे, लेकिन इनके side effects क्या हैं insulin preparations के? Hypoglycemia is one of the severe adverse effects observed in patients in case of overdose of insulin. Insulin allergy, lipodystrophy, insulin dysbiopia, loss of visual accommodation, and of course obesity. The person who is taking insulin become more fat problem. Regarding oral hypoglycemic drugs, sulphonylurea are administered to underweight patients as they increase the weight, increase the secretion of insulin by the beta. अब इसमें ये oral hypoglycemic drugs में जैसे मैंने आपको बताया कि पहला जो ग्रुप है sulphonylurea का, वो क्या करता है? Administered underweight patients as they increase the weight. कैसे ये ब्लड शुगर रिड्यूस करता है sulphonylurea? उसके मैकेनिज्म को अगर आप देखें, इंक्रीज द सीक्रेशन ऑफ इंसुलिन बाय द बीटा सेल्स. अब बीटा सेल्स नॉर्मली सीक्रेट तो कर रहे हैं इंसुलिन, लेकिन कम कर रहे हैं. तो ये क्या करते हैं? दे एक्ट एज ए whip to the tired horse. They act as a whip to the tired horse and thereby increases the secretion of the insulin. So with this, in addition, that decreases the glucogan secretion by the alpha cells of the pancreas. You are well aware that alpha and beta cells have the opposite actions. Increase the secretion of insulin by the beta cells and decrease the glucagon secretion by the alpha cells. Hypoglycemia may occur as side effect. अब इंसुलिन का मेन जो हमने डिस्कस किया साइड इफेक्ट वो हाइपोग्लाइसीमिया, लेकिन ओरल हाइपोग्लाइसेमिक ड्रग्स में ये सल्फोनाइलूरिया का ग्रुप जो है ये भी हाइपोग्लाइसीमिया करा सकता है. लेकिन दूसरा ग्रुप जो है ओरल हाइपोग्लाइसेमिक ड्रग्स का, जिसमें बेगोनाइड्स आ जाते हैं, मेटफॉर्मिन, फिनफॉर्मिन, नॉर्मली वो हाइपोग्लाइसीमिया नहीं कराते as compared to the oral hypoglycemic drugs of the sulphonylurea group. सल्फोनाइलूरिया अब यह है कि भाई एक फीमेल पेशेंट है, प्रेगनेंसी में अगर हम वो प्रेग्नेंट हो गई तो इट्स लाइकली यू माइट हैव टू स्टॉप द सल्फोनाइलूरिया बिकॉज Sulphonylureas are contraindicated in case of pregnancy. Severe hepatic or renal dysfunction, other endocrine dysfunction in Raynaud's disease. तो अगर एक पेशेंट नॉर्मल ओरल हाइपोग्लाइसेमिक ड्रग्स ले रहा है लेकिन वो फीमेल पेशेंट प्रेग्नेंट हो गई है तो उसमें हम सल्फोनाइलूरिया से उसको स्विच करके हम इंसुलिन पे ले जाएंगे बिकॉज sulphonylureas are contraindicated in pregnancy. Regarding another group of oral hypoglycemic drugs, biconides increase the peripheral utilization of glucose. They increase the peripheral utilization of glucose, also decrease the glucose absorption from the GIT. Biconides, in contrast to sulphonylurea, do not decrease the blood sugar level in normal subjects, but decrease the blood sugar level in all types of diabetics. Diabetes में blood sugar को कम करते हैं, लेकिन normally वो hypoglycemia नहीं कराते ये biconides का जो ग्रुप। तो ये बेगोनाइट्स में आ गया। फिनफॉर्मिन दूसरी इसकी ड्रग है, फिनफॉर्मिन मेटफॉर्मिन। तीसरा ग्रुप थायोलिडीन ध्यान से, ट्रोग्लिटाजोन वाज द फर्स्ट थायोलिडीन इंट्रोड्यूस्ड बट डिस्करेज्ड बिकॉज ऑफ हेपेटोटॉक्सिन। ट्रोग्लिटाजोन को डिस्कार्ड किया गया, उसके बाद रोजिग्लिटाजोन, पायोग्लिटाजोन कैरी लेस रिस्क ऑफ सीरियस लिवर डिसफंक्शन, तो इसीलिए उनको आजकल हम यूज करते हैं थायोलिडीन ज्ञान ग्रुप में। दे स्टिमुलेट द परऑक्सीसोम प्रोलिफरेटर एक्टिवेटेड रिसेप्टर। This nuclear receptor regulates the transcription of gene encoding proteins involved in carbohydrates and lipid metabolism. Glutazones increase the glucose uptake in muscles and adipose tissue, inhibit hepatic gluconeogenesis, and have side effects on lipid metabolism and distribution of the body fat. थायोलिडीन ड्यांस के ग्रुप में जैसे हमने उसको पहले ग्रुप ड्रग को देखा कि वो लिवर डैमेज करे थे, फिर रोजिग्लिटाजोन और पायोग्लिटाजोन को दिया। ट्रोग्लिटाजोन को नहीं यूज करते, रोजिग्लिटाजोन पायोग्लिटाजोन प्रेफर करते हैं। appear to induce pioglitazone and troglitazone appear to induce cytochrome P450 and can reduce the serum concentration of the drugs. ये उसमें drug interactions में आ जाएगा. They can reduce the serum concentration of drugs that are metabolized by these enzymes. You are well aware that cytochrome P450 is an enzyme responsible for the degradation of white receptor. So when some other drugs are being used in combination with thiazolidins, they could affect their action, pharmacological action. Specifically metabolized and can reduce the serum concentration of drugs that are metabolized by these enzymes as oral contraceptives and cyclosporine. अल्फा ग्लूकोसाइडेज इनहिबिटर, ये चौथा ग्रुप है। अब हमने जो जितनी ड्रग्स अभी तक डिस्कस की उसमें एक तो इंसुलिन होगा जो पैरेंटली दे रहे हैं। ओरल हाइपोग्लाइसेमिक ड्रग्स में डिफरेंट ग्रुप्स जो हमने डिस्कस किए वो सल्फोनाइलूरिया, बेगोनाइड्स, थायोलिडीन और चौथा है उसका अल्फा ग्लूकोसाइडेज इनहिबिटर. The fourth group of drugs that we could say that it could be used orally, Acarbose and Miglitol are carbohydrates and the logs that act within the intestine to inhibit alpha glucosidase, an enzyme necessary for the conversion of complex starches, oligosaccharides and disaccharides, monosaccharides that can be transported out of the intestinal lumen into the blood. Alpha-glucosidase inhibitors. Acarbose is a carbohydrate analog. Acts within the intestine to inhibit alpha-glucosidase. They produce the reaction by inhibiting the enzyme alpha-glucosidase, an enzyme necessary for rapid absorption of most sugars. So, post-parental hyperglycemia is reduced. अगर हम खाने से पहले अकारबोस और मिग्लिटोल दे देते हैं तो नॉर्मली जो ब्लड शुगर इंक्रीज होता है खाने के बाद उसको रिड्यूस करेंगे. तो they reduce the post-prandial hyperglycemia. That drug has no effect on fasting blood sugar. Flatulence, diarrhea and abdominal pain result from increased fermentation of unabsorbed carbohydrates per bacteria. ये डिफरेंट ग्रुप्स जो अभी हमने डिस्कस कर चुके हैं इंसुलिन में, जैसे हमने डिस्कस किया तो उसके डिफरेंट टाइप्स हैं. शॉर्ट एक्टिंग है, लिस्प्रो है, रेगुलर है, क्रिस्टलाइन है, इंटरमीडिएट एक्टिंग है, स्लो एक्टिंग है. देन ओरल एंटी डायबिटिक्स ड्रग्स में हमने 4 ग्रुप्स इंसुलिन सीक्रेटोगास जिसमें सल्फोनाइलुरिया आ गए, बेगोनाइड्स डिस्कस किए, फेनफॉर्मिन, मेटफॉर्मिन, थायरोइडिन, बियॉन्स ग्रुप. तीसरा ग्रुप हो गया अल्फा ग्लूकोसाइडेज इनहिबिटर्स. चौथा ओरल एंटी डायबिटिक ड्रग्स में आ गए ग्रुप. ये इंसुलिन के डिफरेंट प्रिपरेशंस हैं. अल्ट्रा रैपिड एक्टिंग, इंटरमीडिएट एक्टिंग, लॉन्ग एक्टिंग. Long acting, you will have longer the duration of action. From the peak is normally from 16 hours. Ultra short acting, insulin glargine, that is a very short duration of action. Drug interactions, hypoglycemic effects of sulfonylurea may be augmented by NSAIDs. You are well aware. Non-steroidal anti-inflammatory drugs बहुत commonly used देते हैं for pain and inflammation. Coumarins वो anticoagulant group drug है. Uricosuric drugs as sulfonylurea, alcohol, monoamine oxidase inhibitors, some antibacterial agents as sulfonamides, some antifungal as miconazole and fluconazole. Hypoglycemia जो हमने थोड़ा सा डिस्कस कर लिया है, they all have been reported to be severe hypoglycemia when given with sulfonyl group. The probable basis of interaction is competition for the metabolizing enzymes, thiazides, glutatics, corticosteroids to decrease the action of sulfonyl. अब इसमें एक पॉइंट हमने पहले भी डिस्कस कर चुके हैं कि भाई इसमें एक तो हाइपोग्लाइसेमिया होता है, एक अनकॉन्शियस हो जाता है, कोमा में चला जाता है बिकॉज ऑफ इंक्रीज ब्लड शुगर. दूसरा डिक्रीज ब्लड शुगर लेवल की वजह से भी कोमा चला जाता है. हाइपोग्लाइसेमिक कोमा में क्या होता है और कोमा में कीटोसिस में क्या होता है? If you look at the slide, no food, too much insulin, unaccompanied exercise leads to the hypoglycemic coma. Or coma with ketoacidosis, too little or no insulin, and infection and ill health for several days. These are how you can differentiate and distinguish between hypoglycemic coma because of the diabetic ketoacidosis and then hypoglycemic coma. उसमें मॉइस्ट स्किन आपको मिलेगी, ड्राई स्किन एंड टंग होगी, ब्रेस्ट कीटोन्यूरिया, ब्लड में हाइपोग्लाइसीमिया, ये हाइपोग्लाइसेमिक कोमा में होगा. ये हाइपर